My name's Stephen Roblin. I'm the Senior Medical Director at Alnylam Pharmaceuticals, and I'm responsible for our ATTR amyloidosis program. I'd really like to start by really thanking the HFSA and today's panel for their partnership on launching this inaugural CardioBite series focused on ATTR amyloidosis, which is really an area where research and evidence and clinical care are just evolving so rapidly. As I'm sure our panel tonight will attest, we're seeing just growing recognition of the disease, improved diagnosis, major advancements in management, including with RNAi-based therapies. And all of these topics, including gaps and opportunities, will be really expertly covered across our time tonight and in this entire series. It's just a really exciting time with real potential for everyone involved to change the course of care for patients. And we're just so committed to supporting independent peer-to-peer education, collaboration, meaningful dialogue, and really proud to be part of efforts like this to help move the field forward. And I'm just so looking forward to this session today and the future. And with that, I'll hand it over to our moderator for tonight, Dr. Ronald Wutelis.
Terrific. Thanks so much. I also want to thank the HFSA as well as Alnylam for sponsoring this event. This is an extraordinarily exciting time in the field of ATTR amyloidosis. Do I dare call this the hottest area in cardiology? I think I do dare. And it's because we have a disease here where we understand the science and the pathophysiology, and there have been huge breakthroughs in both recognition and diagnostic modalities, and of course, even larger breakthroughs with effective therapies. And so what we hope to do over the course of the next 30 minutes or so is to lay the foundation of where we are in the space, and specifically to go over some of the recent studies that were presented at ACC and a couple from the ESC heart failure meeting. And fortunately, I am joined here, so I should introduce myself. I'm Ron Wutelis. I'm a professor of cardiovascular medicine at Stanford University and co-director of the Stanford Amyloid Center. And we are really lucky to be joined by two expert panelists, Dr. Deepa Gopal from Boston University and Dr. Natasha Saraswat from University of Chicago. And so what we're going to do is I just want to give a very brief overview of the current state of ATTR amyloidosis therapies. And then what we'll do is go through one by one through 5 studies. And one of us will give a brief overview of what the study was and what the conclusions were. And then we'll have some questions back and forth between us. And then I really encourage people to put questions in live here, and we will try to get to as many of those as well. So without further ado, let's start by talking about the current state of ATTR amyloidosis therapies. We've gone from having nothing just a few short years ago to now having 3 FDA-approved therapies for ATTR cardiomyopathy: tafamidis, acoramidis, and vutrisiran, all shown to be highly effective in really well-done phase 3 randomized double-blind clinical trials. And we have 4 approved therapies for ATTR polyneuropathy, as you can see on your screen, not the focus tonight, but just remarkable to think how we've gone from nothing to where we are now. There's also investigational approaches, which include gene editing and antibody depleter therapies that we look forward to getting data on in the coming years. So with that as background, I now want to go through 5 studies which were picked because they, I think, highlight interesting areas. Some of them are sub-results from the clinical trials. Some of it is where we're going. And so I want to start here with this first one. And this is a abstract by Jarian and colleagues. And this was evaluating the relationship between cardiac structure, function, and clinical outcomes, as well as the impact of vutrisiran in the HELIOS-B trial. Now, the HELIOS-B trial was the landmark clinical trial that led to the FDA approval for vutrisiran, a RNA silencer, for ATTR cardiomyopathy. So what this study was looking at was the association between baseline echo parameters and all-cause mortality. It also looked at the effect of vutrisiran on the echo parameters. And finally, it looked at the effect of what the change were in the echo parameters between baseline and month 18, and then subsequent mortality after month 18. So let me summarize the results, and then I'd love to turn to our panelists to get their thoughts about how they use echocardiographic imaging in this disease. So the results were as follows. So one was that there was a clear association between baseline echo parameters and subsequent all-cause mortality. So for example, for left ventricular ejection fraction, for every 5% increase in the ejection fraction, you had a hazard ratio of 0.89 for all-cause mortality. Even more impressive results, I would say, for global longitudinal strain, which makes sense for this disease, which is so heavily a diastolic dysfunction disease, where a hazard ratio of 0.58 for every 5% absolute increase in GLS. So that was the first thing. The second was looking at the patients who were treated with vutrisiran as opposed to placebo had favorable effects at 18 months across ejection fraction, global longitudinal strain, E to E prime, all statistically significant. So vutrisiran not only affected clinical outcomes, but positively affected imaging outcomes. And then finally, I thought quite interestingly, was that when you looked at the association of the change from baseline to month 18, and then looked at the subsequent all-cause mortality, that patients who had negative changes in EF as opposed to stability or positive changes did worse with a hazard ratio of 0.85 for every 5% increase in EF. Same with GLS with a hazard ratio of 0.63 for every 5%, and same for ED prime. So what this shows is no question an association between both baseline as well as change in imaging parameters with outcomes. So with that, maybe I'll start with Dr. Saraswat. How do you use imaging, in specifically echocardiographic imaging, not just in diagnosis, but in following patients with this disease?
Yeah, so this, first of all, thank you for having me. Pleasure to be here, and this is an exciting time in amyloid, as you said. I look at this study in some ways as a game changer for how I practice. Truthfully, up until recently, when we didn't have too many therapeutic options, I didn't feel like echoes would change a lot of what I did. And I would certainly have a lot of patients that came in and said, well, should we be getting, echoes every 6 months? Should we be getting echoes every year? And I'd be like, I don't know. What is it going to show us? Sure, if I see a dramatic change in ejection fraction, that might show that we're headed in the wrong direction, but I don't have too many things to offer beyond what we're doing in the first place anyway. This changed a lot of what I do, and that now I feel like there's something more to follow, something a little bit more clinical that I can associate what I'm seeing with the echo on, and that may actually cause me to change a therapeutic, the way I approach the therapies. I do think, again, these isn't like a huge study where I'm going to say it changes everything I do and put so much stock into it, but it might make me stop and say, maybe it's worth getting another echo at a year. Maybe if we're seeing other clinical parameters that are changing, maybe it's worth saying, hey, is it worth changing therapy again? I think it's also interesting to me as an advanced heart failure transplant person, right? I'm not necessarily going through and looking at everybody's E to E prime on every single echo that they have. And now I might take a little more time to say, that makes sense. E to E prime in my head is like looking at the wedge, right? And that's how I correlate it hemodynamically. And to say that there actually would be a potential improvement in somebody's wedge pressure means a lot to me as a heart failure person.
Terrific. Thank you. So I've been accused of being a bit of a nihilist with getting imaging on a longitudinal basis because I'm not sure how it'll change things. Dr. Gopal, do you get regular echo imaging once you've gotten the diagnosis? And if so, how frequently?
Yeah, so thank you again for the opportunity to be on the session. So I'm at BU Amyloidosis Center, and at least our general practice has been yearly evaluations of individuals with ATTR cardiomyopathy. I find that serial imaging provides an additional data point among the many data points that we often gather. I think as clinicians treating this disease, We are talking to the patient, understanding their functional capacity. We're looking at biomarkers, whether that be the natriuretic peptides, prealbumin, troponin, from a more classic staging criteria that we often use for biomarkers. And of course, I find imaging as one more group of parameters to think about it, because, and I think this may come up later as we talk about things, we are suddenly faced with multiple therapeutics. And I think the burning question is, when do we implement, what is the initial therapy? And then when do we implement changes? And when is it not working? And so I think this gives a little bit more weight in that we can think about leaning on imaging, like perhaps there are aspects where they have stability in functional capacity and maybe in biomarkers, but we're seeing progression. And we have seen this in our center where we see progression actually in an ejection fraction that isn't necessarily being tracked. And there are discrepancies with individuals. They can be stage 1 by biomarker, but have 18 millimeter walls and significant like low EF. So I think really this is one more piece of data that I hope over time as a field, we're able to put these all together, and maybe we need better risk stratification using multiple variables to kind of help us when we're at the bedside. So I do think yearly interval helps, and there are certain features that are helpful. I find that when RV dysfunction goes down, we often see many of those individuals starting to get into more trouble clinically. And so I think it's one more data point of what we see clinically. I think this data supports that echo data can be prognostic as well and can be another point for thinking about therapeutic changes.
Terrific. Okay, thank you so much to you both. I want to keep us moving to make sure we're on time. So we're going to move to the second study. And I'm actually going to turn to Dr. Saraswat to discuss this one because she was the first author. So take us through it, if you could, please.
Sure, thanks. So we basically, in this second study, we looked at changes in serum TTR in patients in the ATTRibute study. So the ATTRibute-CM study, as we know, was acoramidis versus placebo. Acoramidis is a TTR stabilizer, and we were trying to understand the value of serum TTR in these patients. And what we did see is that in the modified intent to treat population, that there was a significant relationship between baseline and change in TTR at day 28. And then that correlated with a risk of cardiovascular mortality and cardiovascular hospitalizations over 30 months. I think the numbers here are interesting, and that even a 1 milligram per deciliter change in TTR showed a decrease, risk reduction of 5.5% risk reduction in cardiovascular related mortality. You take that a little more, 5 milligram per deciliter change, more risk reduction to 24%. Same thing, it's a little more, 10 milligram, 43% risk reduction. Similarly, on cardiovascular related hospitalizations, a change in 1 milligram per deciliter of TTR brought down the risk reduction at almost 5%, and subsequently 5 and 10 as well. So we're seeing that TTR seems to be a reasonably potent marker of predicting somebody's prognosis. And I think that's an interesting way of saying, not only do you see a change and you're measuring the delta from where they started, but you're also going to take a look at, things very early on. To have such a rapid change at 28 days, I'm usually not getting biomarkers that frequently, but to get a rapid change at 28 days, I think is impressive. But I'll hear what you guys have to say too.
Yeah, I think really interesting data. Maybe I'll ask Dr. Gopal, how do you use serum TTR measurements in your patients?
Yeah, absolutely. So we generally, our practice has been to, when you first see an individual that you're kind of evaluating for ATTR cardiomyopathy, again, in addition to the biomarkers we talked about, troponin, natriuretic peptides, checking prealbumin or the TTR, transthyretin, is really a good way to go. As we have found, generally individuals that have a transthyretin level, a prealbumin level less than 24, can often confer greater risk. And those with genetic ATTR, we often find can be quite low as well. So, and what is very interesting is with institution therapy, and this is across all therapies that we have seen, particularly with stabilizers, diflunisal, tafamidis, as well as acoramidis, is that you do see an increase in TTR level, which does indicate stabilization of the protein. And I think often, anecdotally, we have that tracks with clinical progression, in my opinion. at least at this point. When you start someone on therapy, often you see them at that 1 year. And I agree, Dr. Sarswat, I have never checked a prealbumin at 1 month, so I don't know how that is in the other therapies. But I can say at 1 year, anecdotally, we can see a mean increase between 8 to 10 has been published as well in the other stabilizers. So we do know that increase can be seen. What it does at 1 month with other stabilizers, I think, is unknown. And I think this is really a provocative piece to show that kind of rapidity that we're seeing that in this agent specifically. So again, it's a really nice way. I think sometimes clinicians and patients themselves are trying to figure out, are they doing okay on the medication? And I think it's a nice data point to arm ourselves as well as the patient to provide that kind of feedback that, you may not be feeling different, but we can see there's biomarker evidence that you're probably seeing stabilization. And now with your data, this is actually nice to say, and this may confer improvements in outcomes, which I think is really powerful.
Great. Thanks so much. Really interesting data. And just for anybody in our audience, because this point I think sometimes causes confusion, just to emphasize, when patients are treated with stabilizers, we want to see the TTR levels go up. That's a marker of stabilization. Of course, with silencers, where they are working by knocking TTR levels down, we want to see them go down. So again, a little counterintuitive at first when you say this is a disease of TTR depositing, but actually the increase is a good thing when treated with a stabilizer. All right, let's move on to the next study. And thank you, everybody, for who's entering questions. We are going to try to get to as many of them as we can get to. Let's move on to the next study, which I have shown on the screen here. And this is getting at something different now, which is diagnosis. And so I imagine most everyone in our audience knows that most patients these days are diagnosed with ATTR cardiomyopathy via bone scintigraphy, which in the United States is typically technetium pyrophosphate or PYP scans. They do have their downsides, though. Number one is that they are not sensitive for AL amyloidosis. The scans can be positive or negative. They certainly aren't sensitive for most other rare kinds of amyloidosis. And there are some other diagnostic challenges with particularly patients who might have early disease. So there is an agent, goes by the name AT01 or 124 iodine evazametide, that has been developed and is in studies this is a PET-based agent and saying, can this offer higher accuracy in diagnosis? So this was a very interesting study led by Dr. Masri at OHSU. And this was a prospective study of this agent, which I want to emphasize is a pan-amyloid agent. So it should light up with any form of amyloid infiltration. And in this study, they did whole body PET MRIs to try to assess the diagnostic accuracy and look at the tracer distribution in patients who either were suspected to have or who had confirmed diagnoses of systemic amyloidosis. And they had a total of 97 patients, and it was a mix. 57 ended up having cardiac ATTR amyloidosis, 20 had cardiac AL amyloidosis, 3 had rare forms, APOA1 or APOA4 amyloidosis, 8 had systemic amyloidosis but without cardiac involvement, and 17 were ultimately found to not have systemic amyloidosis at all. And what they found in this study was that there was a 100% among these 97 patients sensitivity and specificity in detecting cardiac amyloidosis, meaning no false positives or false negatives. And within it, they showed one very nice figure, I thought, where they showed an example of a patient who clearly had early ATTR cardiomyopathy. In fact, it was biopsy-proven wild-type ATTR amyloid cardiomyopathy, where the MRI was not suggestive and the PYP scan was not suggestive, proving again that for early disease, it would be nice to have a better marker. So Dr. Gopal, maybe I'll turn to you. What is your experience with PYP scans? Do you think we need a better agent?
Yeah, certainly. I mean, I think it has been a breakthrough modality for us for sure in ATTR cardiomyopathy diagnosis. I think the overall prevalence is increased just to the fact that we can have a non-invasive opportunity. So I think the credit should go to that tracer really kind of like really escalating and elevating the field for sure. But there are aspects where the sensitivity could be optimized. I think we often do see these cases where we are perhaps diagnosing, even earlier now. There's just such an increase in awareness in individuals that may have involvement in soft tissue, and we're trying to ascertain, do they have early cardiac involvement? We're starting to see a lot more evaluations in that way. And so it is great to think that there could be an opportunity to identify earlier. And I think even with this tracer agent, there are some thoughts that because of the mechanism, we may be able to get a little bit better idea as well as about burden. To your point that we may be able to pick up earlier disease states. So I think that's where it may be very nice to help us identify individuals earlier that may not be picked up as easily readily on either our current technetium scans or even MR in this one case that you highlighted, to really institute therapy from a very early perspective, which I think will be groundbreaking in preventing any significant form of the disease from a cardiac perspective.
Perfect. Well, for the sake of time, I'm going to move on to the next study here. This is one I'm well familiar with. So I had the privilege of collaborating on authorship on this. And this was titled Vutrisiran Reduces All-Cause Mortality, CV Mortality, and CV Events in Patients with ATTR Cardiomyopathy. This was another analysis from the HELIOS-B trial. Again, that was the phase 3 trial of Vutrisiran in ATTR Cardiomyopathy. This was looking at data from the trial, but really drilling down more on some of the particular endpoints. And this was looking at all-cause mortality, CV mortality, CV events. So this includes hospitalizations and urgent heart failure visits, and then those specific ones, CV hospitalizations and CV urgent heart failure visits and heart failure hospitalizations. And it was looking at the effect of vutrisiran, and it also looked at it based on whether or not patients were on baseline tafamidis or not. As a reminder, in the HELIOS-B trial, there were about 40% of patients who were on baseline tafamidis, and then, of course, got randomized to either vutrisiran or placebo. And so the finding from this was that vutrisiran was effective across every single one of these endpoints. I won't read through all of the hazard ratios for you. You can see them on your screen. And what I would note most of all is the really impressive effect that it had on all-cause mortality. So the hazard ratio for the overall population was 0.64. The monotherapy, meaning they were not on baseline tafamidis, was 0.61. And combination therapy, though this wasn't statistically significant because the trial wasn't powered for this analysis, the hazard ratio was right around the same, 0.66. So really impressive, actually, the most impressive results in all-cause mortality among our major ATTR cardiomyopathy clinical trials. And really, again, shows what an effective agent this is. So maybe Dr. Saraswat, I will turn to you with a question that comes not only from this, but from one of the audience questions. I'll read the audience question. How do you decide who to start on vutrisiran? Do you use it as an add-on therapy with a stabilizer or instead of a stabilizer? That's a big question. What are your thoughts?
Oh boy. Yes, this is a question I get all day long, every day. And the truth is, I don't know. I mean, I think we're still in a nebulous area. Certainly patients that are hereditary, that have more of a neuropathy, those are patients that I'm more apt to go straight for the silencer than to put on a stabilizer first. And then I think a lot of it is a conversation with the patient in terms of first-line therapy, on pills versus injections, feasibility of going potentially to an infusion center for vutrisiran versus taking pills at home, BID. And kind of just explaining, the duration of how well we've known these therapies, what we know, and what fits for the patient and their family. Again, I think is a little bit less murkiness in some of the hereditary patients with polyneuropathy, but that's kind of how I approach it to start. I think the add-on therapy is a very challenging thing here. And, now we've been faced with this clinically since the end of March. Do we add this to every patient who's already on a stabilizer? Do we add this to patients that are going in the wrong direction? And I guess I would argue probably the latter. I'm not jumping to add, whereas I think one of these people who earlier adopted combination therapy, I'm not jumping to add vutrisiran to every single patient who's on a stabilizer if I see their biomarkers are doing well, they're clinically doing well. And I think, again, the additive, not harm, but the additive challenge to a patient and their family of coming to an infusion center and getting an injection every 3 months. Certainly, if I see parameters going in the wrong direction, they're getting admitted, perhaps they have new arrhythmias, their quality of life is suffering. They have autonomic dysfunction. I guess that would be another big thing that I certainly address. Then I'm much more likely to add a silencer or potentially even switch, depending on how things are.
Thank you. I want to be mindful of time, but this is a question that has been repeatedly asked here in the Q&A. So, Dr. Gopal, just real briefly, what are your thoughts on combination therapy?
Yeah, I think we don't know is the bottom line, but I don't know, and I struggle personally, and our center has had many discussions regarding this. Of if you are truly impairing production, is there additional value to stabilization, and what are we stabilizing? I think is one question that's been raised. There is a specific situation where we have had individuals that have been on a silencer that we do not see a prealbumin level exceeding a less than 3 or whatever your undetectable value is, where they still have residual transthyretin that's active and may not be fully silenced. And in those individuals, we have felt that maybe a stabilizer could be beneficial, particularly if we see clinical progression. So that's been the main situation where I have felt a bit more comfortable in thinking about combination therapy. But I think the jury's still out, and this, I hope, more as we get more drugs moving in across the centers, we'll be able to glean more data from our clinicians and be able to guide us in our decision making.
Terrific. Thank you. Okay, let's move on to the last study we're going to talk about. This isn't actually a study. This is more the announcement of a study. So this is TRITON-CM. This is a phase 3 study to evaluate the efficacy and safety of a next generation silencer, nucresiran, in patients with transthyretin amyloidosis with cardiomyopathy. So this is a really exciting agent. So the study that is planned, it's a 1,250 patient study, so a large study who are going to be randomized 2-to-1 on nucresiran or placebo. So what is nucresiran? Well, there's a couple things that are very exciting about it. So one is that it's now an every 6-month injection, so even less frequent than vutrisiran, which is an every 3-month. The second thing is it achieves very rapid knockdown of serum TTR, and it achieves really impressive knockdown and sustain. So the data from the phase 1 is as follows, that it achieves more than 90% knockdown by day 15. So 2 weeks after getting the injection, more than 90%. Number 2 was that from the phase 1 data, the peak knockdown was more than 96% by day 29, and that this maintains for more than 6 months with very low intersubject variability, which is why it's an every 6-month dosing. And there were no significant safety signals from the phase 1 data. Now, just to give, by comparison, when you look at the current silencers, you're usually somewhere about 80 to 85% knockdown, and it's also not as quick as this. So this gets us quite a bit more, and though we don't technically know for a fact that lower is better, that's say 96% is better than 80 or 85%. I think we have every reason to suspect that, and it certainly would follow what we see in AL amyloidosis. So this trial will be starting soon. It's quite broad in its inclusion criteria, NT-proBNPs between 300 and 8,500, so all the way down to 300, capturing people with early disease, ages 18 to 85, and then some other standard exclusion criteria, but really quite broad, including both wild type and variant patients. Primary endpoint is a composite of all-cause mortality and recurrent CV events, with secondary endpoints of time to CV event or all-cause mortality itself, recurrent CV events itself, and change in KCCQ. Maybe I'll turn to Dr. Saraswat and just ask your thoughts about this and maybe about the current clinical trial space and what you're excited about.
Yeah, so I think this is exciting. I'm excited to be involved in Triton. I think it shows some promise. I think as we go away from just a focus of mortality, more into quality of life as our patients are living longer, happier, healthier lives, less frequent medication, first of all, it's always better. Second, I think the most striking thing when I saw the inclusion criteria was that proBNP, right? Unlike all of our other current trials that we've talked about, this is a much lower proBNP. We're catching people earlier at a less sick state, which is where we think that they will benefit the most, but also certainly where it's more challenging to show a significant benefit when we look at the data at the end of it. But I think, this is where the field is headed, to catch these patients early. So I'm excited about that. And I think that, overall, something like this can show a long-term benefit overall for quality of life. I do look at this as similar more to the CRISPR gene editing trial by Intellia, in that it's a less frequent, whereas the Intellia is just a one-time infusion. It does have more of a knockdown, similarly to the CRISPR gene editor, more like 95% prevention of, the creation of the TTR protein. So similar in that way. But I think the burning question is always, do you need that, right? Is 95% better than 85%? I don't know, maybe. It sounds good. So I think it's exciting, and I'm excited to be part of it.
Terrific. There's one more question I want to get to. Maybe we'll ask Dr. Gopal this. Do we know the overall impact of knocking down serum TTR long-term, especially if patients are advised to take vitamin A replacements?
Yeah, great question. I think, at this time, we have been very diligent in all of our siRNA studies to really be recommending daily vitamin A. I think time will tell. We have, the therapies have only been out for about, 6 years or so in terms of the published data, and we're continuing ongoing monitoring. So I think that is something that continues to be followed closely. I have not personally heard of long-term effects, and Dr. Vitale, I would defer to you as well, because I know you're an expert in the field if that has been any emerging data, but I think something we're looking out for, and I think it's a counseling point whenever I do talk with someone, that the longer term data, we still don't know. And I think to these kind of questions of efficacy, if you're knocking down more, is there going to be a signal that pulls up? I'm not sure yet that we know that.
Yeah, thank you. Yeah, I would say it was certainly a significant concern of mine, and I think others before the trial started, this rather abundant protein in the blood. Is it okay to just knock this down by 80, 90%? I would say that from my perspective, the data so far is very encouraging with that. Patients are required to take a vitamin A replacement, either a multivitamin or supplement of vitamin A, but there really has not been any evidence of clinical vitamin A deficiency in the trials. There have not been meaningful thyroid abnormalities, because it is, again, a transporter of thyroid hormone as well, but one of many. And we just have not seen long-term effects. And we now have had patients, when you start from the early trials of RNA silencers, this isn't 1 or 2 years now. We're talking about over a decade from early trials. So I'm encouraged. It's true, of course. Look, we do not have data for a patient knocking it down for 30 years, of course. But in terms of in the time frame that we've had it, thankfully, from my perspective, we haven't seen any important safety signals. I guess I will address one final question that I saw. How would you treat a patient with combination ATTR cardiomyopathy and polyneuropathy? And I would say that for a patient with ATTR polyneuropathy, real ATTR polyneuropathy, in 2025, they need to be on a silencer. And those are the agents that are approved. I think that we do have the advantage now of having one agent that is approved for both polyneuropathy and cardiomyopathy, vutrisiran. So that would typically be my pick now for a patient with true mixed phenotype disease. I think the combination therapy, should they get a stabilizer as well, as we heard from our other two panelists, the answer is we don't really know the answer to that. Okay, we're just about out of time. So maybe just for 30-second closing from our two panelists, final takeaways. Dr. Saraswat, why don't you go first?
Sure. A lot of exciting stuff obviously happening. I think we're blessed to have multiple therapies to be able to choose from, to even be able to have that discussion with our patients, I think is amazing. I'm really excited. I guess I didn't get to talk too much about avuximotide, and I think that really is going to be something very exciting to help us not only with early disease, but to understand really the systemic manifestations of amyloid. We're seeing so much more liver, kidney, spleen, and for certainly patients that have mutations that we don't always pick up by PYP or other types of amyloid as well. I think there's a lot of exciting stuff that's coming down the pipeline, and I hope this field continues to grow, and we got a lot more to do.
Thank you. Dr. Gopal, 30 seconds or less.
All right, sounds good. I think we have a large armamentarium that continues to grow, and I think surveillance with our patients, really talking to them what they're up to, doing functional capacity, doing a routine set of biomarkers, getting functional cardiac structure and function data is really part of our standard of care that we should offer. And I think that will also help us guide how to think about escalation or changing a therapy when we see these individuals, because we have so many more tools to offer. And I think it is an exciting time. We can finally have conversations with individuals that have advanced disease as well as very, very early disease. And I think that's really exciting that we haven't had that before.
Great. Thank you so much. As I said at the beginning, I agree with my two colleagues, just an incredibly exciting time in the field of ATTR cardiomyopathy. I cannot believe if you had told me from 10 years ago where we would be today, I truly would not have believed it. And the future is really bright. There's so much happening in the amyloid space, as we heard, both on the diagnostic and particularly the therapeutic side. And what's to me so satisfying in this field is that it was an understanding of the pathophysiology of this disease that directly led to the therapies. It was not an accident that just about every therapy that has been tried in this disease has worked because they've been well designed. So with that, I want to thank Alnylam Pharmaceuticals who sponsored this. I want to thank HFSA for this inaugural event. There will be a survey, so please check the link in the description to complete an evaluation of the program, and we really do appreciate everyone's comments. You can see some upcoming programs that are on your screen, and here are some resources from CardioHub on amyloidosis. So thank you once again for joining us, and go out and diagnose and treat amyloidosis, everyone.